All right. Hopefully everyone's doing well. Excuse me. The lab yesterday was incredibly industrious, really productive. I think it seems like a lot of people are beginning to integrate and synthesize the knowledge. It was really nice to see you all kind of giving yourself little mini scenarios and actually going through the process of mixing medications. And so in that vein, I just want to give you all a heads up as to which medications you kind of want to focus on when it comes to the psychomotor skills testing on Tuesday. So when it comes to giving IV bolus or IV push medications, these are the medications that you really want to be most familiar with because they're the more commonly administered ones. And so they would be the ones that you would most likely encounter on the exam. Let's see here. Epinephrine, 1 to 10,000 concentration. Amiodarone, atropine, lidocaine, calcium chloride, adenosine, diphenhydramine, ondansetron, dextrose 50% in water. I understand many of you administer dextrose 10%, but you do need to be familiar with how to properly administer dextrose 50% as a bolus. Push dose epinephrine to include mixing it. Let's see here, fentanyl, naloxone, and morphine. So those are some of the common meds that you'd run into. And so that would, one of these would be, there'll be several different options depending on the station you go to. It'll all be randomized, but of all the medications you could potentially encounter, those are the ones you want to be most familiar with. When it comes to piggyback infusions, again, we're going to focus on the more commonly encountered medications, so or ones that are relatively easier to administer. So let's see here: lidocaine, promethazine, magnesium sulfate, dopamine, an epinephrine drip, and TXA. So those are the medications you want to be comfortable with, and you want to focus in on when it comes to administer the med administration final exam on Tuesday. Okay. In addition to that, just remember the chapter summary assignments will be due on Tuesday as well. Someone brought to my attention that there's a table I think toward the end of the chapter summary assignment, and it's a table, it's supposed to be a conversion exercise. And I looked at it, and it is indeed very confusing. So if that you run into that table and you're not sure what to do, just put an X through it. I'm fine with that because it does appear legitimately confusing to me. So I will not hold that against your grade if you don't complete that specific confusing table there. All right, let's see here. I think that is all of the major housekeeping that I need to get through. And with that in mind, are there any questions before we move on? All right, I think I've dealt with everything in chat, so we're good there. All right, well, we had another review quiz that was due this morning, review quiz 3. So how about we just go ahead and go through that one together before we pivot into the major lecture topics today. I should say that I also have approved all of the labs that were sent through as of 0800 this morning. So if you did not send your lab through by this morning, I have obviously not had a chance to approve it. So those skills won't count toward your portfolio. But those of you that did, you're good to go there. Let's see here. Let me pull up that quiz, and then I'll go ahead and share with you all, and we'll go through it. And then I think we have one more review quiz 4. 4, but that isn't due until next week. And so we will review that on Tuesday morning before we go into lecture. All right. So let me go to quizzes here. Let me go to share. All right, there we go. Quiz 3. There we go. Okay. So which of the following would not be considered an SSRI? So sertraline, fluoxetine, paroxetine, those are all SSRIs. Procainamide is a antidysrhythmic, specifically a class 1A antidysrhythmic, so that would not be an SSRI. Which of the following is not considered a benzodiazepine? So diazepam, lorazepam, and midazolam are all benzodiazepines. Lisinopril is an ACE inhibitor. Which of the following would be the best agent to treat seizure activity? So let's see here. Midazolam would be the best anti-seizure drug given that list. Which enzyme is responsible for the breakdown of monoamines? All right, so you got cytochrome 3 oxidase, ATPase, monoamine oxidase, and cytochrome P450 enzyme. So what do you all think there?
MAO.
Yep. Yeah. Monoamine oxidase. Yeah. Monoamine oxidase and then catechol O-methyltransferase, or COMT, are the two major enzymes responsible for the breakdown of monoamines, like serotonin and dopamine, norepinephrine. Which of the following are potential side effects of SSRIs? So we got erectile dysfunction, irritability, anxiety, or all of the above. All would be the best answer there. Which class of agents can have sodium channel blocking and anticholinergic side effects? So we've got let's see here, the SNRIs, the monoamine oxidase inhibitors, the selective serotonin reuptake inhibitors. There are some SSRIs like bupropion that have sodium channel blocking effects, but both anticholinergic and sodium channel blocking effects would be the tricyclic antidepressants. Okay, patient on antidepressant eats tyramine-rich foods and presents with hypertension and tachycardia. Which class of agent is this patient likely taking? That would be the monoamine oxidase inhibitors. Which of the following is commonly given for its mood stabilizing effects? Of this list, lithium would be the best answer. Which agent works by blocking 5-HT3 receptors? So that's 5-HT is 5-hydroxytryptamine or serotonin. So diphenhydramine works by blocking it's an anticholinergic, so it blocks muscarinic receptors. It blocks histamine 1 and histamine 2 receptors. Ranitidine or Zantac is a histamine receptor blocker. Promethazine is also a histamine and a histamine blocker and an anticholinergic. And then ondansetron or Zofran does work primarily by blocking serotonin 3 receptors. Okay, which of the following agents may help treat GERD, gastroesophageal reflux disease, ulcers, possible upper GI bleeding by blocking proton pumps in the stomach and decreasing hydrochloric acid production? So of all of these, lansoprazole would be the one that is a proton pump inhibitor. Lansoprazole, esomeprazole, Prilosec, and Prevacid. Metoclopramide is the GI drugs. It's referred to as Reglan, and it can help with gastrointestinal secretion and nausea, but its mechanism of action is it's hormonal actually, and it is not at all related to the proton pump inhibitors. And then ranitidine or Zantac is a histamine blocker and reduces acid through inhibiting histamine receptors in the GI tract. Okay, which agent has the highest risk for causing movement disorders such as dystonic reactions due to antagonizing dopamine receptors in the brain? So Sublimaz, does anyone know what Sublimaz is?
Fentanyl.
That's the trade name for fentanyl. Anectine is succinylcholine, that's a depolarizing neuromuscular blocker, lorazepam. Promethazine, right? Because promethazine, not only is it a histamine blocker, not only is it an anticholinergic, but it is related to prochlormazine or thorazine, which is an antipsychotic that blocks dopamine receptors. And so that is a potential side effect when it comes to promethazine, is acute dystonic reactions. Okay, which of the following is a highly lipophilic drug that's commonly used for ongoing sedation infusions, but is known to cause hypotension? So fentanyl. Well, can fentanyl be used for sedation? What do you all think?
Yes.
Yeah, you could actually mix a fentanyl drip and administer an infusion of fentanyl. But fentanyl is not, it's not super hypotensive. Metronidazole, well, metronidazole, also known as Flagyl, is a type of antibiotic. Lansoprazole is a proton pump inhibitor. So the best answer would be propofol or Diprivan. Okay, which of the following has a metabolite known to decrease the seizure threshold? So hydromorphone is known as Dilaudid, morphine, fentanyl, meperidine or Demerol. And actually it's the meperidine, and we talked about its metabolite normeperidine that decreases the seizure threshold and can increase the risk of seizures, particularly in more seizure-prone people. Which of the following decreases stomach acid by blocking gastric histamine receptors? So xylocaine is kind of an old school name for lidocaine. Lansoprazole is a proton pump inhibitor. Pantoprazole is also a proton pump inhibitor, but ranitidine or Zantac is a histamine blocker, as well as cimetidine or Tagamet. Okay, naloxone antagonizes the action of opioids at which receptor? What do you all think?
All of them.
Yeah, it's a great antidote. Now, the one that is most concerning from a clinical standpoint tends to be the mu receptor. That's the one that gives you the sedation, respiratory depression, but naloxone is very good at antagonizing opioids at all receptors. All right. So any questions over the quiz, or any questions over any of the quiz material thus far, since we are getting closer to the final exam? All right. Well, with that in mind, are there any questions over the study guide? Now that you all have had a day or two to kind of go through it and look at it, does anybody have any questions over any of the content on that study guide? All right. I don't see anything in Okay, well, then we'll just go ahead and continue on. Right. Oops. Just address that real quick, and then I'll all right, so today what I want to do is I want to talk about a very important class of medications, a couple of important classes of medications. I won't be able to do it great justice or go into any great detail, but we will cover kind of the high points and talk about some of the major side effects and things to anticipate. So I specifically want to focus on antibiotics, antimicrobial therapy, and I'll also talk a little bit about insulins. And then on Monday, I'll focus on oral antihyperglycemics. And we will also talk about lipid and cholesterol medications, because those are very common meds, and there are some various side effects that we want to be aware of on people that take those agents as well. But today we'll focus primarily on antimicrobial therapy. So everybody had the review videos and quizzes, and so in that vein, we will focus our studies on the classes, the major classes of antibiotics, and talk a little bit about what those antibiotics do, how they work in a very general sense. Okay, so here's just a diagram that I've shamelessly using to help better appreciate the major classes of antibiotics. So what you have here is you have a gram-positive cocci or coccus up on the top, and then a gram-negative bacillus down on the bottom, to differentiate gram-positive from gram-negative bacteria, since those are the two major types of bacteria. So you've got your gram-positive up here, and then we've got our gram-negative down here. So let's just talk about some of the classes of antibiotics. And there are many different ways that we can classify these, but we'll try to do something that makes at least some intuitive sense. So what I want to talk about first, I want to talk about medications that are good at disrupting the cell wall. And these include a couple of different types of antibiotics, the so-called cell wall inhibitors. And typically where they work at disrupting the synthesis of something called peptidoglycan. And peptidoglycan is kind of a thick, hard, kind of a carbohydrate, complex carbohydrate-like material that is abundant in the cell wall of gram-positive bacteria and far less abundant in gram-negative bacteria. So cell wall inhibitors do tend to have more activity against gram-positive organisms. It's not always the case, but that's kind of a general rule of thumb, if you will. And so some classic examples of cell wall inhibitors include the penicillins. And the penicillins are actually the very first antibiotics to be discovered in the 30s and 40s. And does anyone know the story of how antibiotics were actually discovered? It involves a guy by the name of Fleming. I believe that's how his last name is spelled. Might have two M's. I think it's one M. Anyone know the story?
Didn't it start with like mold on dirty dishes?
Yeah. It was mold. So he was culturing bacteria in little dishes. And he noticed that some of the dishes were contaminated with mold, a certain kind of fungus. And the ones that were contaminated with fungus inhibited growth of the bacteria. And so he hypothesized that perhaps the mold was secreting some sort of substance that was inhibiting the growth of the bacteria. And that substance, of course, was called penicillin. And that was the first of the antibiotics, the so-called penicillins. It was very effective against gram-positive organisms like Streptococcus and Staphylococcus. And so that was the beginning of antibiotics. It was kind of a mistake, kind of an accident. Sometimes that's the way it goes. So those are the penicillins. Other drugs that disrupt the cell wall are the cephalosporins. So the penicillins and cephalosporins are the two major categories of cell wall inhibitors. Now the cephalosporins are further subdivided into what are called generations. And the generation really refers to the gram-positive or gram-negative nature of the cephalosporin. So the earlier generations tended to have more gram-positive activity. For example, the first generation cephalosporins like Keflex or Kefzilin is the generic name, is almost entirely gram-positive. And then you had your second generations, things like Kefzil, and then your third generation of cephalosporins tend to be more what we call broad spectrum. And broad spectrum means that they cover both gram-positive and gram-negative. And a classic example of a broad spectrum third generation cephalosporin is something called Ceftriaxone. It's commonly used even to this day, Ceftriaxone. Does anyone know what the trade name for Ceftriaxone is? It's one you run into quite a bit. It's called Rocephin. Rocephin. And then you have your fourth and fifth generation cephalosporins, which are more specialized in their, and so these tend to be more narrow spectrum. The fourth generations really focus on something called Pseudomonas, a very specific type of bacteria, Cephapime. And then your fifth generations focus primarily on Mrsa. Does anyone know what Mrsa is? What does that stand for? MRSA.
Methicillin resistant Staphylococcus aureus.
Yeah, so when bacteria, specifically gram-positive bacteria such as staph, right? So staph and strep, right, are like the two major organisms that cause a majority of the gram-positive bacterial infections that we see, you know, cellulitis, skin infections, joint infections, pneumonias, and so on. Staph and strep account for a large number of those infections. And so when staph, specifically Staph aureus, specifically becomes resistant, so it becomes resistant to the penicillins and the cephalosporins, and then there is another another antibiotic called methicillin, which is kind of like, okay, the penicillins and cephalosporins aren't working, let's try methicillin. And if the methicillin is not particularly effective, then we call it MRSA, methicillin resistant Staphylococcus aureus. And then if it becomes resistant to MRSA, or it becomes resistant to methicillin, then there is another cell wall inhibitor called vancomycin. And vancomycin is one of like the last medications that we have in our arsenal. There are a couple of others that actually came to the market in the 1990s that might be tried. And once it becomes resistant to vancomycin, then it is referred to as VRE, vancomycin resistant Enterococcus, right? And so VRE tends to be even worse because it is resistant to virtually all, and in some cases, all antimicrobial options that we have available. All right. There are other types of resistant organisms as well. For example, there are some other classes of antibiotics known as the carbapenems. And the carbapenems also disrupt the cell wall. And so if methicillin isn't working and vancomycin isn't working, we may put them on a carbapenem, and these are also cell wall inhibitors, right? So you've got your penicillins, your cephalosporins, you've got methicillin, you've got vancomycin, and you've got your carbapenems. And if the carbapenems don't work, then we call it CRE, carbapenem resistant Enterococcus, right? So MRSA, methicillin resistant Staph aureus, VRE, vancomycin resistant Enterococcus, and CRE is carbapenem resistant Enterococcus. All right, and so hopefully the nomenclature of the different resistance nomenclature makes sense. There are some other resistant organisms. For example, tuberculosis is becoming resistant in many cases in certain areas of the world. Tuberculosis, it's a mycobacteria, M. tuberculosis is resistant to every antibiotic we have available. It has its own kind of nomenclature. It's extreme. The worst form of it is something called XDR-TB. Extreme drug-resistant tuberculosis. And that's the one that we are most concerned about because it is resistant to pretty much all available antimicrobial therapy. All right. So the penicillins, the cephalosporins, the carbapenems, methicillin, and vancomycin are all fundamentally cell wall inhibitors. And the chemical structure of these antibiotics is all different. The penicillins have what's called a beta-lactam ring in them. And what happens is as bacteria become resistant, they actually develop enzymes that degrades the beta-lactam ring and breaks the antibiotic down. And then that's what makes them resistant, helps them become resistant to drugs like penicillins and cephalosporins. And because of penicillins and cephalosporins are very related in a lot of ways, if somebody has a true allergy to a penicillin, right, there is approximately like a 10 to 25% crossover with cephalosporins, right? So if you're doing your history and your patient has a true allergy, right, like they had anaphylaxis, not a side effect, right? So lots of side effects to antibiotics, and we'll talk about some of them, like a true allergy, right, where they difficulty breathing, angioedema, low blood pressure, right, anaphylaxis, there is substantial crossover. And so if you see that a cephalosporin has been ordered, you need to question that order and see if an alternative antibiotic would be best for those patients. All right. So there is that crossover when it comes to penicillin and cephalosporin allergies that you need to be aware of. All right. And So the disruption of that beta-lactam ring is what allows the bacteria to become resistant to a lot of the frontline antibiotics. And then they have to modify the antibiotic with different chemical structures. And then the bacteria, right, that's a selection pressure, and that selects for bacteria that can evade those newer antibiotics and so on and so forth. It's a perpetual arms race, really. All right, so those are the cell wall inhibitors. The next major group of antibiotics are broadly categorized as protein synthesis inhibitors. And maybe what I'll do is I'll do that in a different color. Okay, protein synthesis inhibitors. Now, this is actually pretty cool. So what actually synthesizes or produces proteins inside of cells? You guys all tell me what's the manufacturer, what's the device that manufactures proteins inside of cells?
Is it the ribosome?
The ribosome, right? So remember back to the central dogma of molecular biology. If a cell wants to make a protein or needs to make a protein, there is a gene or set of genes that codes for that protein. And those genes are contained within the DNA in the nucleus, right? And so what happens is, the DNA helicase comes, the DNA needs to be opened up and unwrapped from the DNA helicase, and there are different enzymes that are involved in that. And the DNA gets copied, right? You make a carbon copy of those genes, and that is called translation. So the DNA gets turned into or translated into RNA, and then RNA leaves the nucleus, and the DNA stays inside of the nucleus so it can stay protected. And the RNA goes out through little nuclear pores and essentially takes a little ride on a little highway called the rough endoplasmic reticulum. It's like a little highway. And when you look at a cell under a microscope, you can actually see this like little highway, little dots all over it. And that's why we call it rough. And those little dots are the ribosomes, and the RNA comes in. The ribosome reads the RNA, and that tells the ribosome, hey, you need to combine these amino acids to make these polypeptides, right? And then what happens is when you add enough amino acids, they begin to fold, and you get your conformation, your protein, and that's known as translation, right? Where the RNA gets translated into a protein. The good thing is that the subunits of the ribosomes vary in different organisms. And so bacteria tend to have what are called 30 and 50S subunits, whereas human beings have different subunits, right? And because the ribosomal subunits are different, we can develop agents that focus on those subunits and leave the subunits in our ribosomes alone. And so when we look at different antibiotics that inhibit protein synthesis, some examples are the macrolides. The macrolides are a large group of antibiotics, and they are primarily gram-positive. So if you have staph and strep that is not highly resistant, macrolides are a potential consideration. And they inhibit specifically the 50S subunit of the ribosome. All right. And these include drugs like azithromycin, clarithromycin, or erythromycin. Azithromycin is known as Zithromax. So those are the macrolides. Now, another class of protein synthesis inhibitors are the tetracyclines. The tetracyclines inhibit protein synthesis at the 30S subunit as opposed to the 50S subunit. And some examples of the tetracyclines are tetracycline and doxycycline. Whereas the macrolides are more gram-positive, the tetracyclines tend to be a little more broad spectrum, both positive and negative. All right. Some other types of bacteria that work by preventing protein synthesis are the lincosamides, clindamycin is an example of a lincosamide. Clindamycin, you might confuse it with a macrolide, but it's actually a lincosamide. It essentially, lincosamides essentially do the same thing as macrolides, however, because they also inhibit protein synthesis at the 50S subunit. So the macrolides and lincosamides are fairly related. All right. Like the macrolides, they tend to be very gram-positive, and so staph and strep are what tends to be covered by the lincosamides. All right. And then finally, the other major group of protein synthesis inhibitors are what are known as the aminoglycosides, And these include medications like streptomycin, tobramycin, and gentamicin. These have very potent gram-negative coverage as opposed to gram-positive or broad spectrum. And these tend to focus on the 30S subunit. All right. So macrolides and lincosamides are more gram-positive. The tetracyclines tend to be more broad spectrum, positive and negative, and the aminoglycosides tend to be more gram-negative, more narrow spectrum. All right. So those are the protein synthesis inhibitors. All right. The next major category of agents are agents that, broadly speaking, prevent DNA from functioning, inhibit, they technically inhibit protein synthesis, but they don't do it at the ribosomes. They actually do it by inhibiting bacterial enzymes responsible for the proper copying and storage and retrieval of DNA. And I will do this in green. And so these include the fluoroquinolones. All right. And the fluoroquinolones, some classic examples of those are things like ciprofloxacin or cipro, levofloxacin or levaquin. Cipro tends to be gram-negative, whereas a levaquin or levofloxacin tends to have a little more gram-positive activity. But roughly speaking, these agents are broad spectrum, and they inhibit DNA gyrase or topsomerase, right? And so these are enzymes that are responsible for, they are inside of the nucleus, and they're responsible for the proper function of DNA. All right. In addition to that, you have what are called the sulfonamides. And when someone says that they have a sulfa allergy, this is actually what they mean. They're not literally allergic to sulfur. They're allergic to a specific molecular combination that has sulfur in it, that molecular group is present within the sulfonamides as well as other drugs, right? Remember, there are some of the diuretics that have a similar structure, and so you get a sulfa allergy crossover with certain diuretics and other drugs, right? So a classic example of a sulfonamide is trimethoprim sulfamethoxazole, or TMP SMX. All right. And these have fairly fairly good gram-negative coverage, so E. coli, as well as certain gram-positive coverage as well, but these are very commonly used to treat urinary tract infections, and they work by inhibiting an enzyme known as THFA that's needed for this, essentially for the synthesis and production of DNA, right? So these roughly inhibit the proper function of DNA, so I'll include them in that category. All right. The next group of antibiotics that interfere with DNA are the nitrofurans, and these include medications like Macrolide. All right. And these work, roughly speaking, by damaging DNA, and they are also commonly used to treat urinary tract infections. So things like E. coli. All right. And then finally, the last specific agent is something called metronidazole, aka Flagyl. And this also, roughly speaking, works by disrupting DNA. And this is very good at anaerobic bacteria. A lot of the bacteria we've talked about, staph, strep, E. coli, are more aerobic, but Flagyl is really good at covering anaerobic, and Flagyl can also cover certain eukaryotic organisms, certain kinds of parasites and protozoal, right? So Flagyl is sometimes used to treat like weird, like amoebic dysentery and those kinds of protozoal kinds of infections. So it's not purely an antibiotic in the antibacterial sense. So that's just kind of roughly how you can conceptualize antibiotics as, is this a cell wall inhibitor, right? The penicillins, a penicillin, amoxicillin, methicillin, cephalosporins, carbapenems. Is this a protein synthesis inhibitor, the tetracyclines, the macrolides, the lincosamides, the aminoglycosides, or does this inhibit proper DNA function, like the fluoroquinolones, the sulfonamides, the nitrofurans, and metronidazole or Flagyl, which is kind of in a class by itself, since it is kind of a unique antibiotic. And so what people do is, depending on how the patient's presenting, what we do when the patient presents is we figure out, okay, where is the likely location of their infection? Is this a pneumonia? Is this a urinary tract infection? Is this a skin or cellulitis? Is this deep in a joint? Is this involving the central nervous system? Is it like, an infective endocarditis, and so on and so forth? And then what we do is we go, okay, what are the most likely organisms that impact these? And what is the gram stain? Is this gram positive or gram negative? And we'll do what's known as empiric therapy, where you go, okay, it's a gram positive organism and it's a pneumonia. And I know that the most common things are going to be like Streptococcus pneumoniae and things like that. And so initially, when somebody presents with an infection, we will choose antibiotics that cover, broadly speaking, right, based on the gram stain and the location. We'll go, okay, this is probably what we're dealing with. The most likely antibiotics is going to cover, it's going to be this, and this is what I'm going to choose. And that's called empiric therapy. And then what happens is, as more information comes in, as the sensitivity, right? So you do the culture, but it takes 24, 48 hours to get the sensitivity to find out what specific antibiotics we can use. And so you kind of start off more broad spectrum, or sometimes you'll have multiple antibiotics. You'll have different categories to cover as much as you can. And then as you get more information, you can zero in and you can select a more focused or a more narrow spectrum antibiotic when the results of the culture and sensitivity actually come in. So that's roughly speaking how antibiotic therapy works. Now, with that in mind, there are some side effects. There are lots of side effects that we need to be aware of with antibiotics, and I'll talk about some specific examples, and then we'll talk about some general things that you want to be aware of. So right here are some specific examples of specific toxicities and side effects associated with antibiotics. So the aminoglycosides are rather ototoxic, and they are rather nephrotoxic. So ototoxicity is hearing, and nephrotoxicity has to do with the kidneys, right? The aminoglycosides. Tetracyclines, a big one with tetracyclines is photosensitivity and staining of the teeth, particularly in children who receive tetracyclines, or pregnant mothers who get it can pass this on to their children in some cases. The macrolides, a big one here with the macrolides is QT interval prolongation, right? And that increases the risk of torsade de pointe. We've talked about that with other drugs. The fluoroquinolones, we've mentioned this before, right? So things like levofloxacin and levaquin. Spontaneous tendon rupture is a big problem with those, specifically the Achilles tendon. Vancomycin Red Man Syndrome, red inflamed skin. Vancomycin also has some other organ toxicities as well, kidneys. Nitrofurantoin, like Macrolide. You want to think about lung effects, brown urine, linezolid, serotonin syndrome. Penicillins, allergies are very common to the penicillins, and remember that there is, can be a cross sensitivity with the penicillins and the cephalosporins. Okay, clofazimine, you can get skin discoloration, and isoniazide, you can get peripheral neuropathies. Isoniazide, or INH, is a medication that is used primarily to treat tuberculosis. It's one of the primary agents we use to treat tuberculosis. And I'm just going to mention something special about isoniazide, or INH, and that is to say that isoniazide, or INH, is a hydrazine like molecule. So it has hydrazine like properties. And hydrazine is an interesting agent in that hydrazine toxicity actually inhibits enzymes and enzyme in the brain that helps produce gamma aminobutyric acid, GABA. Remember, GABA is a primary inhibitory neurotransmitter in the central nervous system. And so when you inhibit GABA, right, that means that the effects of glutamate increase. You have increased excitatory effects in the brain that are not being kept in check by the inhibitory effects of GABA. And so you get an excitotoxicity that develops, and these patients can develop seizures. Well, let me ask you a question. How do we treat seizures? What's the primary treatment for seizures? Pharmacologically speaking.
Benzos?
Yeah, and what is the basic mechanism of action of a benzodiazepine?
It works on GABA A.
Yeah, so it works by making GABA A receptors more sensitive to the effects of GABA. So here's the thing, for benzodiazepines to work, you actually need to have GABA, right? Because benzodiazepines cannot directly agonize GABA receptors. So if you are not producing GABA because you're poisoned by hydrazine and hydrazine-like molecules, benzodiazepines will not be effective at stopping your seizure. And so this is one of the, it's fairly rare, but this is one of the causes of resistant seizures. Does anyone happen to know what the antidote to this is? And this is something that we run into in the Las Cruces area, believe it or not. It's not due to isoniazide, but it's due to another. It's actually due to the potential for direct hydrazine exposure. And so where in Las Cruces or the Las Cruces area or Doñana County would exposure to hydrazine be an issue?
NASA?
Yep, there you go, NASA. Because hydrazine is used in various rockets and satellites in spacecraft as a fuel and propellant. And so they do work with hydrazine at NASA. And in fact, any of you work at NASA Fire, or have any of you worked at NASA Fire Department? Okay, they actually have a special skill for the antidote, or one of the antidotes that's used in the setting of hydrazine toxicity, and that is something called pyridoxine. And pyridoxine helps reactivate the enzyme responsible for producing the GABA. So you give the pyridoxine, the patient can start making GABA again, and you can get those seizures under control. And that will also work in the setting of, say, isoniazide toxicity, where maybe, a child has gotten into some medication and has taken a bunch of INH and is presenting with hydrazine or MMH, monomethylhydrazine toxicity. All right. So before we conclude the first part of lecture, some other general problems with antibiotics that you need to be aware of. And we've talked about resistance, so I'm not going to talk about that again. So we did talk about antibiotic resistance in pathophysiology, huge problem. But there are some other problems I also want you to be aware of. And we've mentioned them, but super infections are very common, right? So an antibiotic can wipe out the normal microbiome in your gut and allow abnormal bacteria to come in and take over. And so this can increase the risk of things like Pseudomonas, Clostridium difficile, or C. diff, right? These really difficult drug-resistant infections that are hard to treat, as well as fungal infections like thrush, and even, drug-resistant fungal infections that are resistant to your frontline antifungal agents like fluconazole and meconazole and et cetera. So super infections are a big problem, as well as lots of gastrointestinal side effects are fairly common. You also want to think about specific side effects, right? Like tendon rupture, specific classes of antibiotics, right? Stevens-Johnson syndrome, SJS, we mentioned that yesterday, is going to be a little more common with antibiotics. All right. So somebody who's on antibiotics is going to be at risk for some of these other things. And so you want to take that into consideration. And then the last question is, can we administer antibiotics as paramedics?
We can monitor, right?
Yeah, so we cannot initiate antibiotics, but once an antibiotic has been ordered and hung, then we can continue to infuse that during transport. And that's very important, because if you are transporting somebody with a severe infection, or you're transporting somebody who has sepsis or severe sepsis and or septic shock, right? remember, one of the core measures is the timely delivery of antibiotics. And so if that patient is not receiving antibiotics, it's your job to make sure that that happens, right? Hey, I don't see an antibiotic order. Do you want to get an antibiotic going before we begin transporting this patient, right? So that onus might fall onto us to ensure that that good continuity of care occurs in the setting of a severe infection, sepsis, septic shock. Okay, any questions before we take our first break? Anybody have any questions over those? All right, well, let's see here. It's fairly close to 9:30, so how about I just see you all at 9:45. Welcome back, everybody. Welcome back, everyone. All right, anybody have any questions before we move on to the last topic that I want to get through today? Anybody have any questions? All right, I think I'm clear in chat. All right, excellent. So the next thing I want to talk about, the last thing I want to talk about today are our insulins, rather. And the reason I say are because insulin is just not one single thing. It's actually a class of medications. So the insulin can be highly modified to do some different things. So let's just talk about insulin. As soon as this screen sharing starts, there we go. So let me ask you all a question. What are the indications for insulin? Like, why would we actually give somebody insulin?
Hyperglycemic event.
Okay, yeah, so that's kind of the main reason is to treat or prevent hyperglycemia. And what is hyperglycemia?
The sugar's not entering the cell, correct? Or
No,
the body's inability to produce the insulin.
maybe, but what is hyperglycemia, just generally speaking? When somebody is hyperglycemic, what does that mean?
High blood sugar.
Yeah, that means that the sugar in their blood is abnormally elevated, right? So you have an abnormal elevation in blood sugar. That's hyperglycemia. All right. Right? Remember, this is medical terminology, right? We need to make sure that we can understand these basic terms of medicine, right? Emia means blood, hyper means elevated, and glyce refers to glucose, right? So elevated glucose in the blood. And this is one of the primary indications. There are some others that we'll talk about as well. And some specific disorders associated with hyperglycemia, of course, the elephant in the room is diabetes. Specifically, what type of diabetes?
type 1.
Yeah, maybe.
It starts with an M.
Type 2.
Starts with an M. Yeah.
Malaise, something like that.
Mellitus, diabetes mellitus. Right? Diabetes mellitus. There are different types of diabetes. All right. So that didn't turn out real well. So diabetes mellitus is the one involving sugar, right? There is another type of diabetes called diabetes insipidus. And that has nothing to do with sugar. Does anyone know what diabetes insipidus is, or DI?
You don't produce insulin?
Okay, so diabetes insipidus, just to review, it has nothing to do with sugar. All right, so that's the hint. Diabetes insipidus has nothing to do with sugar. But does anyone happen to know what diabetes insipidus is? So diabetes does not mean sugar specifically, all right? Diabetes means to waste away. That's where that word derives from. It is a kind of wasting away. And so diabetes insipidus is when people have in insipidus a marked loss of water. And so they are urinating massive amounts of water. And this is due to a hormonal imbalance. This is due to a lack or due to low levels of antidiuretic hormone, ADH, also known as vasopressin. So if someone is not producing antidiuretic hormone, their body is not able to as effectively hold on to water, and they begin diuresing substantially. And so they're wasting away. Their diabetes is due to an insipidus loss of water. Now, the other major type of diabetes is diabetes mellitus, which is a metabolic disorder involving sugar, right? And back in the day, when people got diabetes, right, they would waste away, right? We would see this typically in children and young adults. They would have this disorder of they would pee a lot, they would breathe very rapidly, they would get very dry and dehydrated, right? And they would just slowly waste away, and their mental status would go down, and there was just nothing we could really do to help them. There were some like really strict diets of like high fat, high protein diets that could help prevent some of this from occurring for a certain amount of time. But in general, these people would just waste away, and they would die a slow, agonizing death of just kind of shutting down. And that's where the term diabetes mellitus, because their blood sugar was very elevated and their body just could not use that sugar. And of course, we now call this the first major identified form of diabetes mellitus, type 1. So sometimes referred to as type 1 diabetes, or IDDM, insulin-dependent diabetes mellitus, all right? Or this is sometimes referred to as juvenile onset diabetes, because this tends to occur in younger people. And this is characterized by an inability to produce insulin. Inability to produce insulin, right? That is type 1 diabetes. We think that there may be an autoimmune component to type 1 diabetes. And it is often occurs following a viral infection in a juvenile or adolescent patient. They will recover from a viral infection, and then we suspect that there's some autoimmune reaction that occurs, and the body attacks the islets of Langerhans in the pancreas and causes destruction of the alpha and beta cells in there that are responsible for insulin and glucagon production. All right, that's type 1. The other type is sometimes referred to as type 2 diabetes, also referred to as NIDDM, non-insulin dependent diabetes mellitus. That's somewhat of a misnomer, because many people with type 2 diabetes have to go on insulin eventually. And with type 2 diabetes, these are people that make insulin, but what happens is their body cells become resistant to insulin. So insulin resistance is the major problem, right? And this often occurs in the setting of somebody who has chronically elevated blood sugar, and so their body has to produce more insulin. And just like anything, right, if you take like opioids, right, if you take an opioid for an extended period of time and you have large amounts of opioids circulating through your body, right, the receptors, the opioid receptors will downregulate, and they will become, right, less sensitive to that opioid. And then you will have to consume more of that opioid to produce the effect that you're looking for, right? And that's known as tolerance. Same thing is happening here with insulin, right? The receptor for insulin on the cell, right? Because you have these chronically elevated blood sugar and chronically you have more insulin being produced than normal, the cells will downregulate and they will become tolerant and they will become resistant to insulin. And it takes more insulin to get the effect, right? So that's the major pathophysiology between type 1 and type 2 diabetes. Now, in addition to that, there are some other things that can cause hyperglycemia, and this may or may not occur in a diabetic patient. All right, so I'm going to mention them. Pancreatitis. What is pancreatitis?
Inflammation of the pancreas.
Yeah, inflammation of the pancreas. This can cause hyperglycemia in somebody without diabetes, right? People who are pregnant can sometimes have hyperglycemia, right? And this is referred to as gestational diabetes. And this may or may not occur in a diabetic person. Yes, sir. Go ahead. I see your raised hand there.
Hey, Chris. So in the hospital, there's always a concern for like the pancreatitis patients of them being like really dehydrated, and I can't find anything on why they would be really dehydrated. If you can help me out with that.
Yeah, so pancreatitis does lots of bad things, unfortunately. And one of the things that it's associated with is nausea and vomiting. And so just simply due to the fact that these people may be nauseous, they may be vomiting and losing fluid, they're not taking fluid in, they can become hypovolemic. And if their sugar becomes elevated because they are developing hyperglycemia due to the pancreatitis, remember the sugar is very hyperosmolar and it's actually going to pull fluid out of the cells and cause intracellular dehydration. So that can also be a part of it. And remember, pancreatitis can cause other things like ARDS, right? It can increase the risk of ARDS and it can cause systemic inflammation. So Ssris and things like that. And so it's a combination of all sorts of things that can cause these people to present with hypovolemia. And just the fact that there are certain risk factors for pancreatitis, like alcoholism or chronic alcohol ingestion, right? That can play a role in the dehydration that can occur as well. So that hopefully that explained it.
It did. Thank you, sir.
Yeah, not a problem. Yeah, good. Another thing that we see, and this is actually something that is sometimes underappreciated, is people that are under a substantial degree of stress or trauma, right? So stress, trauma, major infection, or even a major surgery can increase the risk of hyperglycemia, because these all activate, right? These all activate the general adaptation mechanisms. And a part of that is you have cortisol being released. And we talked about that yesterday with the mineral corticoids and the glucocorticoids. And one of the things that these steroids can do is they can increase the blood sugar. And as well as you have catecholamines, and you have an adrenergic response, right? So the sympathetic nervous system can become activated, and that will also act to increase somebody's blood sugar potentially, right? Shuts down the immune system and ramps up the metabolic, right? So increase your blood sugar and then shut down non-essential systems so you can fight, or you can do a proper fight or flight response. All right. Another area. Okay, so I think that's good. I'll just mention some types of hyperglycemic syndromes. One of the major hyperglycemic syndromes, which is almost entirely seen in type 1 diabetics, is the DKA, or diabetic ketoacidosis. And then the other major type of hyperglycemic syndrome we see in people without type 1 diabetes, either type 2 diabetes or people that have pancreatitis or some other major illness, infection, or injury, is something called HHS, and that stands for hyperglycemic hyperosmolar syndrome. So they have a very high blood sugar without the ketones, so not breaking down fats, not utilizing fatty acids, because they can still make insulin. HHS is sometimes referred to as hyperglycemic hyperosmolar non-ketotic coma, or HINC. Means the same thing. All right. Now another indication for insulin, and we mentioned it earlier on when we talked about calcium channel blockers and beta blockers, is insulin may play a role, or does play a role, in treating calcium channel blocker and beta blocker overdose. Remember, in calcium channel blocker and beta blocker overdose, the heart is depressed, right? And dumping insulin in can increase free fatty acid utilization by the heart and can counteract some of the effects. And so this is actually considered kind of the primary. This is like one of the primary things that we use in people that have a calcium channel blocker and beta blocker overdose. This is actually kind of considered a frontline therapy, and we generally start by giving them a large loading dose of insulin. This is sometimes referred to as high dose insulin euglycemia, where we'll load them up with 1 unit per kilogram of insulin, and then put them on an insulin drip of like 0.5 units per kilogram per hour, right? And then we'll add, typically vasopressors and inotropic agents into the mix as well. All right, so, and then the other major area where insulin may play a role is in hyperkalemia, life-threatening hyperkalemia, right? Because remember, insulin acts to drive potassium ions back into the cells. So insulin has several different indications. Now, with that in mind, there are several types of insulin, and I want to just talk about them real quickly. And so we can roughly categorize insulin into 4 major categories. Some people go even more than that. Some people break the last category into like long acting and ultra long acting, but we'll just kind of simplify it. So your first category is your ultra short acting. These are the shortest acting. So up here are your ultra short. Stop that. All right. So their onset is 5 to 10 minutes, and they only last about 30 to 90 minutes. They peak in 30 to 90 minutes. So very rapid onset, peak fairly rapidly, and have a short duration of action. These are the ultra short. So things like Lispro, Aspart, glulisine insulin. Let's see, Aspart is sometimes referred to as Novolog. All right, that's a trade name. So that's the ultra short. And then you have what are called the short-acting insulins. And the prototype of a short-acting insulin is something called insulin R, or just regular insulin. And this is the standard insulin that we would commonly see used in the acute or the emergency setting. If we're treating acute life-threatening hyperglycemia or calcium channel blocker toxicity, HINC, hyperkalemia, those kinds of things, this tends to be the insulin that we're using to give as a bolus and to mix as an insulin drip. All of the other types of insulin are not really appropriate to be given intravenously, right? So regular insulin is the major one. So its onset is about 30 minutes to an hour. It peaks in 2 to 3 hours, and then has a slightly longer total duration of action. All right. So those are the short acting. This is regular insulin is sometimes referred to as Novolin R. All right. And then the next category we call the intermediate acting insulins. All right. Things like insulin NPH, for example. NPH is a common intermediate acting insulin. This is a classic example. Its onset is 1 to 3 hours. Its peak is in about 4 to 12 hours. And then its total duration of action can go out much longer than that. All right. And then finally, you have what are called the long-acting insulins. And the long-acting insulins basically kind of mimic your basal insulin activity, just like the tiny amount of insulin that's just released throughout the day, right? And then when you eat a meal, what happens is your glucose spikes, and so you have a spike in insulin. And so oftentimes diabetics they'll give themselves a long-acting insulin to kind of give them that basal coverage. And then prior to eating, they will give themselves a dose of a shorter acting insulin to account for that meal, right? And so it can be a complex mixture of different kinds of insulins. And then to make it even more complicated, there are mixtures of insulins out there. The most common, I will mention one of the most common, and this is something referred to as insulin 70-30. All right. So somebody is on 70-30 insulin or NPH 70-30. What that is that's actually a combination of a short and an intermediate acting insulin. And so what it is, 70-30, is somebody who's taking 70% NPH, so that's an intermediate acting insulin, and then 30% is regular insulin. All right. Oh, and I guess I should give you an example of a long-acting insulin. So something like Lantus would be an example of a long-acting insulin. All right. So again, the only ones that we are administering intravenously is going to be the regular insulin. All the rest of these are typically administered subcutaneously. And they are also working with nebulized forms of insulin as well. And insulin, unlike many other medications, is not administered in grams or milligrams or milliequivalents, as is the case with electrolytes, but rather it is administered in units. And so you have to use a special insulin syringe. And as you all learned, many of you thought that an insulin syringe was called a tuberculosis or a TB syringe, and that's actually not the case. So if the syringe is labeled in units, that's an insulin syringe, right? And the typical conversion is 100 units per milliliter. And that's why I say do not use an insulin syringe for anything other than insulin, because dosage calculation errors could occur if you're drawing up something you're trying to draw up half a milliliter of something and you're using an insulin syringe and you forget the conversion factor. You can just see that's an unnecessary risk for a medication error and an iatrogenic injury potentially. All right. Okay, so that is the major types of insulin. I should also say that there is another concept that you just need to be aware of, and this is a concept known as a sliding scale. Has anyone ever heard of that term, sliding scale?
Heard of it, don't necessarily understand what it is.
Not a problem. So sliding scale insulin is a common way, and essentially what it is, it's a prescription. And so what somebody does is at certain times during the day, generally prior to meals or when they wake up before going to bed, they will measure their blood sugar and they will have a scale. And these scales can vary from person to person, or they can be very general. And so what you'll have is like a blood sugar. And they'll, like, an example would be, okay, if your blood sugar is between 61 and 150, that's milligrams per deciliter, right? The amount of insulin you should give yourself, regular insulin typically, would be 0 units, right? If it's less than 61, then that might be hypoglycemia. And then if your blood sugar is between 151 and say 200, right, then you need to give yourself 3 units. And then if it's between 201 and 250, you need to give yourself 5 units. And then 251 to 300, you need to give yourself 8 units. And then 301 to 350. So you can see this is in 50 milligram per deciliter increments. You need to give yourself 10 units. 351 to 400, 12 units. And then if your sugar is greater than 400, right, you need to give 15 units and call ASAP, something like that. All right, so that would be an example of a sliding scale, right? It's just a prescription for how much insulin you need to bolus yourself with. And the other thing you need to be aware of, there are lots of people, particularly type 1 diabetics, who are really good at managing themselves, that may be on an insulin pump. And so that's a device that can continuously pump insulin into the person. And so it may give them their basal insulin, and then they can program boluses, and they can bolus themselves with insulin, and they can use different types of insulin. And so maybe they'll have their basal programmed, and then they'll bolus themselves with insulin prior to eating or after eating or what have you, and they can manage their sugar very closely with that pump. In general, if you're transporting somebody that has an insulin pump working, if it's working and their blood sugar is under control and they're not having blood sugar problems, just leave it alone. It's kind of the general rule of thumb. However, if they're down and out, or they're really hypoglycemic, or there's some major problem, you can go ahead and just disconnect the pump. And is typically what they'll have is they'll have a little needle a little subcutaneous needle placed in their abdomen, and then they just change the site that they're using from time to time. And you can just go ahead and if you have to, you shouldn't do this as a general rule, but if they're unstable, they're hypoglycemic, the pump's failing or alarming, they're not able to manage it, you can just go ahead and pull that needle, discontinue it, and then just keep the pump with the patient, and that's fine as well. So that's kind of like insulin pump 101. In general, if the patient's awake and oriented and managing themselves, you generally just kind of let them deal with it, because they're going to know a lot more about themselves and their insulin pump and how it works and all the nuance and detail. And it's a general rule of thumb, you kind of default to them as the subject matter expert when it comes to that pump, unless there's some potentially life-threatening issue that you need to deal with, or that the pump is maybe causing. All right, any questions over insulin, or insulins, should I say? All right, make sure I've addressed everything in chat. All right, well, if there aren't any questions, let's go ahead and wrap things up. I know it's just a couple minutes early, but that's fine. You all have a lot of work ahead of you. So we'll wrap it up, and I will see you in lab this afternoon. We will have an open lab to focus on whatever you need to focus on, specifically to get you feeling comfortable for Tuesday when you have to come in and demonstrate how to do this stuff in front of us. In a one-to-one, right? So you won't be in groups, you'll be coming in individually. So there will be a little more stress. And so I just want you to practice mixing and administering and making sure you're comfortable, asking about allergies, going through the rites of medication administration, verifying before you give, right? Don't forget those little details, because those can potentially be problematic for you. You will not have to do high-level critical thinking. We're going to tell you, we will give you an order. You need to give this for this. So you don't need to worry about, oh, well, what are the half a dozen indications? And, well, if it's this, then this is a dose, or if it's that's a dose. We'll tell you, hey, this is a patient in cardiac arrest. You need to administer milligram epinephrine. And then you have to go, oh, okay, I'm going to choose the right concentration, right? And so on and so forth. So really, it is focusing on the administration part of that. All right. Any questions before before I let you all go? All right. Well, thank you all so much. I'll see you this afternoon. Please be safe. I hear the winds are supposed to pick up again. So be safe on your commute if you're commuting. And I'll see you here in just a few. Take care. All right. Get this saved.